Okay, everyone, thank you for the opportunity to present again. Over the years, it's been sort of an annual practice to talk about aminoglycosides. But what's exciting about today is that we're taking this to yet another step. So for those of you who haven't traveled on this journey with us for the aminoglycosides, I'll walk you through a bit of the past, and then we'll talk about what is new in our recent deliberations. So we just trying to make sure I'm advancing here. Sorry. Okay, we started our process in 2014. And at that time, we identified the aminoglycosides as a therapeutic class of great need of evaluation for susceptibility test interpretive criteria, STIC. And the objectives of that work scope at that time were a very basic principle. We wanted to apply modern PK/PD based assessments to a class that hadn't been ever looked at in that regard. We wanted to also not only look at traditional dosing, but extended interval dosing. And we wanted to take that data, PK/PD data, and also evaluate it in the context of contemporary in vitro surveillance data over time, really to understand what had been going on with this class. And then finally, we wanted to understand and consider susceptibility breakpoints in the context of combination therapy and effect site concentrations, two things that are really important when we think about use and PK/PD. So we set out to put together an analysis plan, and this wasn't just to help us, but it was for clarity of thought and to share with other stakeholders. We shared this analysis plan that included a lot of detail with the FDA. And at the time, our thought was, maybe the package insert could be modernized. We weren't sure where this could go, but at the very least, we thought it would be really helpful to show other groups what we're thinking, how we're going to approach this. And the approach included looking through the literature, right, and looking for population PK models that had covariates predictive of PK that we could use for our simulation exercise. The other part of this assessment was to look beyond patients with normal renal function and really look at creatinine clearance groups for the purposes of more than breakpoints, just to understand dosing. And then to conduct target attainment analyses using various approaches that I'm not going to get into in this discussion, but which are detailed in great, with lots of pages, I would say, in our report that is still posted on our website. So we're going to streamline what we're going to talk about in this talk and only look at one approach. But as I said, that report, that lengthy report, is on our website. It was issued in February 2019. Now, the end result of all of the deliberations and assessments we did with dosing to understand not only what the dose would be in the patients with normal creatinine clearance, so 90 to 120, but really what it would look like in the other renal function groups, so creatinine clearance groups that were 120 to 240 or below. And to understand how to get to where we got to in this slide, we started looking at package inserts for traditional dosing to understand what the guidelines for renal adjustment were. We looked at hospitals that had posted their dosing regimens for extended interval dosing to understand, again, what the range was for normal patients and then those with renal impairment. Now, we couldn't find adequate data to guide us for dosing for renal impairment. So we thought, okay, this is an opportunity. Not only are we trying to understand what breakpoint guidelines should be, but this is an opportunity to also try to look at what dosing should be in some of these groups. So as I said, we looked through the literature, we identified population PK models, we undertook this extensive process to simulate patients in each of these creatinine clearance groups. And our goal was to identify dosing regimens that would achieve similar exposures to those in the normal renal group. And this was our pre-step before looking at target attainment. Of course, we focused on the assessments for the normal renal function group when it got down to breakpoints, knowing that we had achieved similar exposures. Now, this is the guts of what helped us get to that dosing table. What you see here are box and whisker plots for all of the renal function groups that I just showed you. And the red bars, the red dashed lines, are the 5th and 95th prediction intervals for the normal group. So the normal group, again, is the 90 to 120. And we're looking at gentamicin as our example. So on the left, we see gent AUC and Cmax box plots for traditional dosing. And on the right, we see extended interval dosing for gent. The top panel is AUC, the bottom panel is Cmin. And our goal was to maintain as many of the data points within the prediction interval for the other creatinine clearance groups. You know, ideally you want 95% of that data in the prediction interval, but we settled for less than 25% on either end of that, the whiskers. We also wanted to keep the Cmins that are above 2 and above 8, above 2 for gent and tober and above 8 for amikacin, less than 20%. So those were the goals. And just to go backwards, this is again the dosing regimens that we ended up with. So these formed the basis for how we handled dosing in the simulations. And again, the probabilities of target attainment that we will go over in this presentation were based on the 90 to 120, with the understanding that other patients had equivalent exposures. The other part of the simulations included thinking about our inputs for non-clinical PK/PD targets. And this is data from Dr. Craig way back from 1991, looking at dose fractionation studies for amikacin against Pseudomonas aeruginosa, asking the question, what PK/PD index is most predictive of efficacy? And as we understand with concentration-dependent drugs, for which AUC to MIC ratio and peak to MIC describe the PK/PD, those were the two measures that were most predictive of efficacy. And then taking this a step further to understand for the pathogens of interest, what is the magnitude of the AUC to MIC ratio associated with the various endpoints that we care about, stasis, 1 log, 2 logs. On the left, you can see data for the murine thigh infection model, and on the right, you can see data for the lung infection model. And the data for amikacin, gent, and tober were all pooled. And you can see that AUC to MIC ratio did a good job predicting efficacy with high R-squared values. Now, taking these functions, and another one for Pseudomonas that I did not show you in the thigh model, but taking these functions and then asking the question, what are the AUC to MIC ratio targets associated with stasis, 1 log and 2 log, you can see what they looked like for Enterobacteriaceae. For the thigh, it was 30, a little bit lower for the lung, close to 15 for stasis. For 1 log, it was 84.3 for thigh, and for the lung, 23.7. And 2 log, you can see how high they got to for Enterobacteriaceae, and frankly, there just isn't probably enough data in that range to be as precise as we'd want to. And that's an endpoint that's probably beyond what we need. And we're going to talk about why I say that in a minute. And then for Pseudomonas, similar to the thigh model, Pseudomonas studied in a thigh model was similar to Enterobacteriaceae studied in a thigh model with 58.3 for stasis, about 84 for 1 log. In 2019, when we issued that large body of work, the decision was made at that point in time to use net bacterial stasis as the non-clinical efficacy endpoint when we were coming up with our recommendations for the STIC. The important caveat was that we assumed that use would be as combination therapy, or if it was monotherapy, that would be in the context of urinary tract infections. Now, we're going to talk about what the validity of those assumptions were in a second, but the breakpoints that came out of those assessments, again, based on stasis, the assumption of combination therapy, are shown in this slide. So you can see that for amikacin, It was 4 and 8 for susceptible and resistant breakpoint, 2 and 4 for gent. Because we had lung models for Enterobacterales and gent and Tobra, we saw that there was a benefit or an opportunity to have a pneumonia breakpoint. And so those breakpoints were lower based on stasis, so 1 and 4 with an intermediate category. For Pseudomonas, based on the thigh only, which is all we had, amikacin breakpoints were similar, but 2 and 8. And for Tobra, it was 1 and 2. And gent, there was just no basis for a breakpoint given the distributions. Now, it's important to step back and think about what we did at that point in time and why. So this slide shows a clinical construct that those of us at ICPD put together a number of years ago for selecting bacterial reduction endpoints for non-clinical PK/PD targets. We use this construct, and as you can see, there's groups of diseases and patient or infection characteristics that are characterized by the endpoint. Net bacterial stasis, 1 and 2 log reductions from baseline. And you can see for net bacterial stasis, for example, we considered that appropriate for patients with skin infections, also for CUTI, IAI, where there's good source control, and BSI, again, where there's good source control and there's active combination therapy. But this was an endpoint that we thought was reasonable for when the consequences of inadequate therapy might be low, and in patients that might have less comorbidities. Now you contrast that with Emax, and where and when would you use an Emax-based target? Well, a number of years ago, we helped the US government pick doses for post-exposure anthrax, and we chose drug exposures associated with the 99 maximal effect. And this was done because the risk of death to an otherwise healthy person was high. Now, that's an extreme example. So it's important to remember that these endpoints are subjective. We don't necessarily have good data backing up all of this, but we try to use some good construct to help us think about this. Now, we've used this construct for picking doses for clinical trials, and when you use this construct to identify a PK/PD threshold associated with failure, but not to avoid a failed clinical trial. So that's our end goal when we're trying to do this for dose selection. We want to get as many patients on the plateau of an exposure response relationship so that you don't identify a PK/PD relationship by the time you're looking at this data in phase 3. It's important to remember that a mouse model can only give us directionally correct information. It doesn't give us the specific prediction of outcome, since there's other factors that influence response besides exposure. So one more important point here is that clinical trial data and exposures from failed programs teach us the most, but we don't always have that data. So that being said, we need to rely on some sort of construct to make reasonable decisions. Now, for CUTI, for which aminoglycosides concentrate in the urine, we considered at the time stasis to be an adequate endpoint for patients for which there's good source control. And then for others, the thought was that the use of aminoglycosides as combination therapy would be sufficient with using stasis as an endpoint. This consideration was also informed by data from recent clinical trials, at least in our hands, where the PK/PD relationships were not identified when all patients achieved PK/PD indices that were above net stasis. But given the variability in the patient population and the desire not to have STIC contingent on the condition of having combination therapy, and because we want to be consistent with scenarios requiring combination therapy for other drugs and other pathogens, we thought at this juncture we would evaluate STIC in the context of a 1 log target without the requirement for combination therapy. And this is consistent with how the FDA is also looking at CUTI. They're also looking at a 1 log endpoint, as are other groups. So in this slide, you can see the current recommendations that were based on stasis in the second to last column, contrasted with the last column, which is based on those if you imposed a 1 log endpoint. So as we just discussed with the first set of assessments, there was a lot of discussion around those proposed changes at the very beginning, and that wasn't that was also the case in this context with our recent discussions. The thought was we don't know how these agents are being used, and we want to have the same rules by class so that adopters of these STIC wouldn't inadvertently apply these in a different scenario and inconsistently. Most of our USCAST members thought that they were more comfortable with a 1 log endpoint. And one additional support for getting on the same page and being consistent with the 1 log endpoint is that as we start to understand what our therapeutic options are and compare rates of resistance, if we do this consistently across these classes, we're going to have a better level playing field. So now I want to show you what data supported these specific values that are in this last column. And this is, again, data that we generated that's in that report, but now looking at it through the lens of a 1 log endpoint. So this is first data for gentamicin and Enterobacterales. And what you see in the top part of this slide on the middle part is the actual percent probabilities of target attainment by MIC that were associated with that 1 log endpoint by the 2 murine infection models that we had to evaluate. The thigh model and then the lung model. And then this is stratified further by the traditional and the extended interval dosing. And you can see for gent that a 0.5 did very well in terms of percent probabilities of target attainment, achieving percentages that were above 90%. And then resistant was defined as 1. And you can see that data overlaid all Enterobacterales in gray, MDR in blue, and CRE in orange. So the next set of slides also go through this sort of outline of how these data are set up. And one important point about the murine lung infection model assessments, those were based on ELF targets in mice that we inferred based on various sources of data, as well as ELF exposures that were modeled based on the available PK data as well. So moving to tobramycin, we can see using the same sort of evaluation, high percent probabilities of target attainment of 90 and above, that 0.5 also was an appropriate susceptible breakpoint for TOBRA against Enterobacterales, and 1 was set for the resistant breakpoint. For amikacin, you can see that with the exception of traditional dosing, extended interval dosing for the lung model achieved 92% probability of target attainment at a 2, and 97% probability of target attainment for a lung infection model. For traditional dosing, it didn't quite get to 90%, but it was 89.3%. Thereby justifying a breakpoint of 2 and then setting the resistant breakpoint at 4. Okay, switching gears to Pseudomonas. Now looking at gent data, but again, here we only have thigh infection model data to look at. We see that 0.5 again is a reasonable breakpoint, achieving percent probabilities above 90%. And for tobramycin, the same thing. 0.5 was a reasonable breakpoint. And you can see, again, the scatter of data, but let's just go back and look at gent. Even though you can see that the vast majority of the isolates are above 0.5, it's really instructive, we thought, to have a breakpoint so that you can just see how suboptimal this drug would be. Many people know that, of course, but we think it's important to illustrate that. But then looking at TOBRA, it is a little bit better, and we'll look at the end at what the impact of these breakpoints are on the percent susceptibilities. Amikacin, we can see that, again, just like we saw for Enterobacterales, traditional dosing doesn't do so well at a 2, but it did well. Extended interval dosing allowed us to achieve percent probabilities of target attainment above 90%, ergo justifying the contingency on high dose extended interval dosing. So before we finalized our thoughts on this proposal to base STIC on 1 log, we considered one additional point, Knowing that TDM is carried out, we asked the question, should STIC be established also using TDM in those patients for which we apply that for? And to consider TDM, we have to have an understanding of targets based on both efficacy and safety. Now, we've just finished reviewing the non-clinical AUC to MIC ratio targets that we considered for the target attainment analyses, and that helped inform our understanding. But for safety, we reviewed the data from various sources. This data is from Mike Ryback and colleagues, and you can see the relationship between acute kidney injury and AUC on the left with traditional dosing, and then extended interval dosing on the right. Only those that got traditional dosing had AKI. And in the worst case scenario, you can see that with traditional dosing, there was a low probability even at an AUC of 100. Probability was, of course, higher with concurrent Vanco use. Other data comes from a New Zealand study that's about 30 years old, but they also studied once daily dosing, and in a range of AUCs of 70 to 100, you can see that out of 100 patients studied, there were very few that had nephrotoxicity. So this range appeared to be safe in this context. So we asked ourselves the question, could we construct a susceptible TDM category? Could we do that given the established non-clinical AUC to MIC ratio associated with 1 log that we've been discussing? That was 84.3 for Enterobacterales and similar for SUD. And using the limited data suggesting safety up to an AUC of 100 for Gent and Tobra, could we actually construct another category? And if we did that, would it be based on an MIC of 1 for Gent and for Tobra? Again, that was where we were drawing the line at susceptible versus resistant. Could we do that, and knowing that we would target an 84 but keep our Cmins less than 2? If we did that, that would then shift our resistance breakpoint to 2. We could have a empiric or a susceptibility breakpoint that really doesn't rely on TDM. We could have another category for TDM, and then we could set our resistance 1 dilution higher. So this was a question that we considered and discussed among our members. But that left a conundrum for amikacin. Knowing that efficacy is co-modeled and efficacy is handled in a similar way, we wondered if we could do the same thing. In the absence of amikacin data, could we take the 84 target and multiply it by 4 and use the target of 340 to help us shoot for a safety target? And could we then propose a susceptible TDM breakpoint of 4 for amikacin? So this was a question that is currently on the table, and for which we're going to be looking for feedback from those viewing this presentation today, or who may look at the presentation after it's posted. So one thing that we wanted to consider as we thought about extrapolating the safety data for amikacin is the original box and whisker plots that we looked at. I showed you the example for gentamicin, but we also have these included in our report posted on the website for each of the other aminoglycosides. And so if you look at amikacin, AUC, and Cmin box plots, you can see that in the case of AUC, we are in that range of about 380 for the vast majority of these renal groups. And if you look at the Cmin, you can see that patients are in that range that we would want to be under, less than 8 for dosing as well. So empirically, we're already there in terms of what we're trying to do with empiric dosing. So maybe it isn't such a stretch to use those goals when we think about TDM, even in the absence of safety data. And again, this is something we'd like your input on. But if we do that, then we have consistent STIC across the 3 agents, amikacin, tobramycin, gentamicin, taking that lower susceptible breakpoint, adding one for a TDM-based breakpoint, and then shifting resistance up by 1 dilution. What's the implication if we do that? Well, the susceptible breakpoint, if we use that, that would tell us for Enterobacterales that 73% of isolates would be susceptible at a 2. If we apply STDM, as we're calling it, for a 4, that would increase the number of isolates to about 94%. Looking at tobramycin, only 55% would be susceptible at the susceptible breakpoint of 0.5. But then applying STDM, an STDM breakpoint, that would get us up to about 83%. And for gentamicin, it would be 68 and 88%. For SUD, amikacin still performed poorly for the lower susceptibility breakpoint of 2, close to 30%. With STDM, that would get us up to 73%. For tobramycin, 62 and 88%. And for gentamicin, as we were talking about earlier, it's really not a SUD drug at all, with less than 10% susceptible. And even with STDM, it still would be a poor option. So this is the implication of the breakpoints that could be finalized and deemed our final at this juncture based on the 1 log endpoint and STTM. Now, as Jason covered in his presentation, there is a consequence of setting these 1 log endpoints for UTI, and it's really an issue beyond the aminoglycosides, and it's one that we want to take a better look at. We do have few drugs that currently have arbitrary, somewhat arbitrary breakpoints, or at least not based on all the data we would like to see for lower UTI. And there's really not a lot of rationale for what informs these breakpoints in a consistent way. And we know that model development is ongoing, as evidenced by the call from the FDA for different proposals. So whether or not CUTI, upper UTI should have additional breakpoint considerations based on something else, either 1 log, net bacterial stasis, or maybe something else, is unclear. We know when we looked at the EPIC data for plazomicin, it's possible that aminoglycosides have unique concentrating abilities that maybe, again, justify a different metric. And there's also a number of studies out there that demonstrate the efficacy of single doses for aminoglycosides. So there's more here that needs to be considered, and we want to take this up with another working group and come back again with maybe more thoughts and hopefully more data as it's generated. So I'll leave you with this last slide, which is what the status of the different SDOs out there are with regard to aminoglycoside breakpoints. So CLSI has recently reviewed breakpoints for the aminoglycosides, and their posting is pending for 2023, but you can see here what the recent decisions were made as, and this is contrasted with the 2022 and older breakpoint decisions, which are mirrored by the FDA breakpoints. So those are really the original breakpoints from many decades right now. Contrasted with USCAST, which also recently adjusted their breakpoints in the last few years. And then the last column is what we've just been discussing in this presentation, which are the proposed USCAST breakpoints. And this is now our open period where we're going to be soliciting feedback. So with that, I'm going to say thank you for listening to this topic again. And I will look forward to at least reading, hearing if there are questions. If we don't address them all now, we will in the future. But Jason, I'll stop here.
So thank you for that. That was fantastic as always. I think there's a lot of interest online, and I think that people probably need to digest this a little bit as we have as an organization, as we've kind of talked through that. There are no specific questions for you at this time. And so the good news for that is that we're going to get to wrap up actually a little bit early here today on our call, on our meeting. So I want to thank everybody for joining us, but I do want to highlight once again that there was a lot that was thrown at you today, and we are aware of that. So please do stew on this, give us comments, give us feedback. We want to hear your thoughts. Within the next couple of weeks, this will be available for you to view. This will be available for you to look at the slide decks that will be posted up on the website. We will have some time for open comment period. We really want to hear from you though, because we know there are clinical implications to switching to some of these things. Having susceptible TDM breakpoints is a novel concept. So please, again, do take some time, think about it, review the data, and give us your feedback. We're open to all comments. And as we kind of led off with today, we're at the point in all of these breakpoint analyses where we want public comment, public feedback, and we will reassess it as necessary. So please do give it to us. We'll really appreciate that. And other than that, I think you're free to be on your way. And all I would just say is that just pay attention to your email. We'll let you know when this stuff is available. But otherwise, thank you for coming today. I want to thank all of our speakers for great talks. And we look forward to further discussion with everybody. So thank you so much.
Thank you, Jason.